right. Good morning, all. Great to see you. Thanks for joining our meeting this morning. I know folks have had some trouble with commuting and school closures and all the things, but we appreciate you all being here. Um, we have a big enough group and a full enough agenda that I think we're going to skip kind of formal introduction. So if folks could put their name and role and organization in the chat, that would be wonderful. And just bear with me for a moment. I'm gonna get ready to share a couple of slides to kick us off. All right, folks are seeing those okay? Awesome. All right, so welcome to our January Child Outcomes and Accountability Team meeting. Just wanted to kind of quickly, I know we have some new faces on today.
Hey, Anna, we do have your slides, but it looks like we have your full desktop too.
Oh, weird. Thank you. All right, I'm thinking that's better. Awesome. I just wanted to quickly kind of reorient folks since we have some new people joining on the call today, to the charge of the Child Outcomes Accountability Team. This is one of 7 Vermont Early Childhood Action Plan committees within the Building Bright Futures Network, and this committee is really charged with improving integration and coordination within early childhood systems, specifically kind of those related to early developmental health and well-being of children and their families. So we tend to focus frequently on issues related to maternal and family and child health, physical health, basic needs, things kind of in that realm. And today, with that charge, we are going to focus on perinatal health and well-being, which is something that we haven't chatted about in a while, but is timely for a number of reasons. So we are going to start by hearing from Dora on the BBF team, who's going to kind of walk us through the recent perinatal health and well-being section of the State of Vermont's Children Report, which is now available. So folks might have tuned in to the briefing or already reviewed this section of the report, but we'll kind of quickly reorient folks to this body of work and also give everyone a chance to ask more questions and engage in more of a conversation around the latest data. And then we are excited to have Katie Leffel and Julie Parent on the call, and they're going to walk us through some of the current priorities and the initiatives of the Perinatal Quality Collaborative. And then ideally we will have time to get into a good discussion about all of the overlap between both of those bodies of work, but also some of the kind of specific challenges or strategies that this group is interested in kind of elevating or championing as a coach team. All right, I think that is all, and I think we're ready, Dora, to hand things over to you.
Great. And thanks everybody for being here. And I'm so excited to, it's been a while since I've been here and excited to talk about perinatal health and well-being, and to learn more about the Perinatal Quality Collaborative, from Katie and Julie in a little bit. This is definitely something that I am still learning about, despite having spent the last couple of months developing this perinatal data spotlight. I want to just, in case you weren't able to tune into the briefing or check out the giant report, this is our mandated report to the governor and legislature on the well-being on the state of Vermont's children. Objective, comprehensive, data-driven assessment. So really, it has this report I'm really proud of, and proud of our team, Jen Schulmeyer, who is here, and I don't know if Kitty Foster is on the call, but absolutely instrumental in the development of this report and putting together a really powerful briefing, as well as the partnerships that we have counted on to be able to put this report together, and especially with around the perinatal spotlight. So folks from VCHIP, and many of whom are on this call, and also Family and Child Health, both from like the identification of this as this year's data spotlight to initial thoughts about what indicators should be included, and then really such an iterative process of the narrative and making sure that we were presenting things in an accurate way. So again, thinking about all of the and I hope that that our presentation will complement what Katie and Julie are going to present in a little bit, and so I won't necessarily get into a whole lot of detail. I also want to just say, if you have a little bit of time and haven't had a chance to watch the briefing, the panel on perinatal health was so powerful. So hearing about both the landscape from Elisa, who's the director of Family and Child Health, as well as from Amy Wenger, who's a home visitor, and then hearing from Jen Rose Brittenham, who is a parent who was diagnosed with perinatal depression and anxiety, and her journey through accessing services, and through that identification and accessing services. Definitely, like, I laughed and I cried. Really powerful. So if you have 30 minutes to take a look at that, I would encourage you to do that. So let's get into the data. Speaking of perinatal mood and anxiety disorders, we know that 25% of pregnant and postpartum birthing people in Vermont were affected by PMADs, and that's compared to 11.5% nationally. Lots of reasons for that. I think the focus on screening through the STAMP grant, the work that Family and Child Health and VCHIP and sort of our mental health folks have worked on to destigmatize and raise awareness about perinatal mood and anxiety disorders leads to some of this. And so the comparison may not be about a higher prevalence, but just higher identification, although it's unclear again here. We don't know a whole lot about paternal anxiety and depression. However, sort of globally, we see that 7.3% of birthing partners and male partners had experienced prenatal and postpartum depression. Through the STAMP grant, in partnership with Mathematica, there was a data brief on the cost of untreated PMADs, which showed that there was an estimated individual and societal cost of $36,000 per birthing parent and their child in Vermont. So another sort of focus area was around substance use during pregnancy. So for children born in 2021, there was at least one substance used in more than 1 in 10 pregnancies. So lots and lots of work has been done over a long time period to focus on alcohol use and cigarette smoking specifically, as well as sort of a broad array of other substances, including illicit substances and marijuana. But there has been this plateau, especially around alcohol and cigarettes. And when we think about the long-term implications of perinatal substance use. Definitely something that we continue to focus on. Neonatal abstinence syndrome is down from 24 per thousand in 2014 to 13.6. And just thinking a little bit about the long-term implications, specifically around opiates during that pregnancy time, the exposure, the long-term implications, again, are significant, and lots of work there. I think that Katie and Julie will be getting into more detail around the maternal mortality review panel, but striking to note that 100% of the deaths that were reviewed were directly related to substance use disorder. When we think about opportunities for intervention and health promotion, lots of longstanding as well as innovative approaches are coming up. So we look at adequate prenatal care, which is both early and regular prenatal visits and care. 86.7% of births of 2021 of the 2021 cohort had adequate prenatal care. And across the board, when you look at breastfeeding and chest feeding, both from initiation to exclusivity to sustained breastfeeding and chest feeding is higher in Vermont than in the US as a whole. A couple of other opportunities when we think about home visiting, we have maternal and early childhood sustained home visiting, which served 421 families and 393 children. But the intensity of those visits, there were 3,000 visits for those 421 families. So really thinking about the dosage there is really important. Parents as Teachers is another evidence-based home visiting program. In the development phase, 21 families with 21 children were served with 315 visits. And that is definitely expanding over, that was in the development phase and is currently expanding. Home-based Head Start and early Head Start home visiting served 308 infants and pregnant individuals. So again, a lot of focus on home visiting. And just a personal aside, I had a baby who's not a baby anymore, almost 3 years ago, and thinking about the impact of going from sort of the increasing frequency right before delivery of getting to almost one visit a week. And then I had a baby, and then there was a 6-week postpartum visit, and then it was done. So the opportunity here around home visiting for development of that relationship and going through this really transformative experience. And again, when we're thinking about the impact of PMADs, that a quarter of birthing parents are affected by PMADs, and we look at the opportunity for home visiting, really significant opportunity there. One of the other really innovative opportunities or interventions, I don't know exactly what the word is, apologies, is around perinatal psychiatric consultation. So there was also a brief in collaboration with Mathematica through the STAMP grant that showed that there were, so this program allows for, especially in our rural state, for professionals to be able to access the expertise of a psychiatric provider, whether it's checking in about medications, whether it's looking for a referral, or just like assurance that we're on the right track, or just checking in about that. Having access to that expertise is so critical, again, especially in a rural state. So at its current funding and staffing level, it is saving approximately $200,000 a year, and with a little bit of expansion around coordination and a little bit more time of the um, psychiatrist, it would save $650,000 per year. Dulce is really, it's not new, and Vermont has been involved in it for a long time, thinking about embedding a family specialist in a pediatric practice. Again, bringing in this expertise so that we don't all have to have that huge level of expertise, that we're really leveraging these and embedding these embedding these best practices and the expertise of family specialists, specifically from the parent-child centers, into pediatric practices. So Dulce is currently expanding from 6 to 9 sites in 2024. Really exciting work going on there. And I don't know if Katie and Julie are going to talk about that at all. Brina, I am sure that you could also jump in if you're on the call. And then another, again, really critical piece of the puzzle here is around paid family and medical leave. So looking at an 18% higher probability of working 1 year after birth for those with paid parental leave, increased household income. But only 47% of birthing parents in Vermont had returning to work sorry, I'm trying to read the small print. So there were 47% who did not have access to paid leave. So lots of the next slide shows a little bit of our recommendations about sort of investment in perinatal supports. We have a huge amount of alignment here. I'm not going to go through each and every one of these, but really there is guidance here around, and these can be used to, and these were all endorsed by the State Advisory Council. Thinking about opportunities to support legislation or inform advocacy, thinking about what information needs to be shared with the legislature or others around investment in perinatal supports this critical period. So I've just shared and talked a lot, and we have this full report. This was 4 pages out of 50, a huge number of like a very large and robust section on basic needs. Shout out to Keely, who I think is on the call, around and Hunger Free Vermont around food security, and some exciting data work there. So lots and lots of information here. We can we'll paste in the link there. And Maria, thank you for the note about that Parents as Teachers is not supporting perinatal care at this time. So apologies for that oversight on my part. I wonder if we can pull down the slide. Yeah, we're on the same page, Anna. So happy to have a conversation, or if we want to move directly on to Julie and Katie. And there are so many experts on this call, so I might I might call on others as we're having this discussion.
We certainly have time if anyone has questions for Dora or the BBF data team. And I see you unmuted. Do you have a question?
Hi, thank you. And I'm sorry, not able to use my camera this morning, but uh,
I think we've lost your audio, Anne. All right, perhaps we'll come back to Anne. Maybe she's in transit. Any other questions?
Or corrections.
did. Hi, can you hear me?
Yeah. Yes.
Okay, I'm sorry about that. I seem to have dropped off. Um, um, Home visiting program mesh also includes responsive home visiting for the perinatal population. I think that's important to include in the list, unless it's only evidence-based practices, in which I think that should be clarified. And I also wanted to share, if people don't know, that the CIS 2024 bundled contract includes a new an expansion of the population that can be served in the case of bereavement by Strong Families Vermont Home Visiting. So for families that have been CIS clients, if they experience loss during pregnancy or postpartum, they can continue with their CIS provider up to through that whole first year postpartum. So that's something that came as a result of the kind of data and information that you've been sharing today. And I don't want to take up too much time, but if there's time, I'd like to talk, you all let me know about the recommendation to continue CIS Strong Families Vermont responsive home visiting through the whole first year perinatal, and how we have thought about that at the CIS state team. So let me know when there might be a good time to do that.
Great. Thanks, Anne. Dora, did you hear the beginning of Anne's point enough to? I just want to make sure because she cut out at the beginning there.
I just about the responsive home visiting being needing to be a part of that. I think we were focusing on evidence-based home visiting. And I think the reason that we wanted to be able to include parents as teachers, and it also clearly doesn't fit in the perinatal spotlight, but I think that it landed in there because it just because of the chapter formatting. But definitely we will note that moving forward. And super exciting, like so meaningful to be able to continue the CIS work and partnership throughout that first year postpartum for those experiencing pregnancy and infant loss.
Absolutely. And I think, and the second kind of point you raised and would like to talk more about in terms of home visiting and the CIS state team, I think would fit really nicely with our conversation after Katie and Julie's presentation, if you don't mind holding that. All right, Katie and then Helen.
Sorry, I know I'm presenting in a minute, so but I wanted to jump in really quickly because I think Margaret Urban had to jump off. But just to bring up the nurse home visiting, the evidence-based nurse home visiting and other CIS practitioners too, not just the evidence-based program. We're trained in the mothers and babies model, which is a mental health support for perinatal people, and have developed a protocol for screening and intervention using that as a kind of a preventative measure for mental health, but also to sort of hold families while they're waiting for other supports. So that's been really exciting and cool. And it doesn't really fit in with our PQC conversation, but I just thought it would be helpful to bring up.
Absolutely. Such an interesting model, and so promising. Again, thinking about those the importance of this time and the mental health connection very, very directly.
Sorry, little commotion here in the office this morning. Helen, I see your hand too.
Yeah, hi. Thanks. Not sure why I'm echoing. Okay, let's try it again.
Just mute.
Okay. Hi. What?
Go for it.
Okay, great. Hi, Helen from CDD at State of Vermont. I have a question. So when you're sharing those numbers, so I'm new to this committee, trying to get a better sense of, so when we're talking about those programs that are in place, what percentage of the need is that meeting? And do we have any sense of what that is? So thinking about what, Dulce and parents as teachers and everything. So what percentage of what need is it meeting at this point, and what are we aiming towards? Do we have any sense of that? And then the second question is, so when you talked about those outcomes and deaths, I'm really interested in terms of some of the, are we talking about death due to health-related incidents, or is it because of due to the exposure to those drugs, or is it, are we looking at child abuse numbers as well? So just trying to get a better sense of and what that looks like.
Thank you for those questions. Really important, and I think I'm going to lean on some other folks in the room here, but just generally, our data across Vermont doesn't answer all of the questions that we wanted to. So for the most part, we are measuring utilization rather than sort of demand or need. So again, thinking about I mean, everything from childcare to home visiting, and even looking at something like wait lists for mental health consultation, or a specific, or like a pediatric practice that is meeting what people are looking for. Is it people might be on more than one. They might have given up on the opportunity. So thinking about just that sort of demand or need is really hard to measure. I'm going to let other folks take on the maternal mortality questions.
Can I ask one question? Could we look at it in terms of like the number of births per year, and to be able to see sort of like what that looks like? County by county, in terms of like how many then are served through, home visiting. What was the program specifically you were talking about that you received?
Yeah.
Yeah,
absolutely. And I think that there's also, for home visiting, there's still eligibility criteria. And so I think if we can I don't have the numbers right in front of me, but it's a great question. And I think, again, something that we are, I mean, just broadly, I think we don't have the capacity that we want. And but we don't know exactly how far away we are.
I think
Probably too general. Thank you, Katie.
I will go into the maternal mortality piece in a little more depth in our presentation, and I don't want to go too far into this. Just thinking in terms of the data for home visiting, it's always a little tricky because there's, you know, the evidence-based programs with robust data in some ways, but sometimes that can be tricky to report out regionally because of, you know, small numbers and things like that. And then there's also just such a, I'm going to say, rich tapestry of other kinds of home visitings across the state that are not necessarily evidence-based, but evidence-informed. Like, for instance, the home health agencies have other supportive services like lactation and other kinds of home visiting. CIS has a wide range of home visiting. The parent-child centers have home visiting outside of CIS. There's doula programs in some places. You know, there's there's early Head Start. But when you are asking about data, that gets tricky because not everybody collects data, or not the same data, and there's no place to pull it together and have like a really great repository for all that data. So it's definitely a priority. The Department of Health is to try to address that, and I know the PQC, and we'll go into that in our presentation. But it makes it complicated because there's so many players and nobody uses the same methods.
Thanks, Katie. That's super helpful.
Anna, this is Brina. Can I just, that was such an important question. I wanted to frame it in the way we've been thinking about it for a long time, because it helps with this integrated table.
Yep.
So if you start with like the base of where are the pregnant people and the new babies, that denominator is like 5,000. And yes, we can count that starting with the idea that we have public policy and very high rates of prenatal care and pediatric health visits, right? So you guys have done a good job thinking of that domain. Like, yes, well, we've access to almost everybody in OB offices and in pediatric offices. And then you go up the ladder and there's a subset of people that find their way to home visiting services, all the complexity Katie, Margaret, others would describe, but it's a growing number, and it's very exciting that we could track that. But then we also have to do the third domain, so there's home, medical homes, and then there's community. And community has a huge opportunity here to show up for families in informal ways and more formal ways. And we could start to try to quantify that, as Katie just described. So I hope that helps people's brain. That's why we keep pushing for thinking about these OB offices, the birth hospitals, and the pediatric offices, because we underrepresent access when we just talk about the community programs. So thanks for the question, Helen.
Thank you for that framing, Brina. I think that's a great foundation for this group to have, and also a good place for us to pivot. But Charlotte, I saw your hand earlier, and do you have a final question for this section? I see you just posted in the chat as well. Perhaps that was your question.
Yeah, no, I don't want to take up space. Thanks so much, though.
Okay, thank you. All right. So most folks on this call are familiar, and we've already heard quite a bit from Katie, but I'm going to introduce Katie Leffel, who's a perinatal nurse coordinator for the Family Child Health Division at BDH, and Julie Parent, who's a project director at VCHIP. And I'm going to screen share your slides, Katie and Julie. So just give me cues if I'm missing.
Perfect. So I'm gonna do the first part here. Good afternoon, everybody. I'm again Julie Parent. I'm here to present the Perinatal Quality Collaborative, also known as the PQC. we can move to the next slide. I just want to acknowledge, and there's a lot of collaborator on this call and a lot of leader and folks that are part of this team. And actually our latest kind of team member from the OB team is here. She started this week. Kyla is here on the call. And we're so excited to have her. She will be, as she put in the chat, she'll be really helping lead the AIM project with the OB faculty there at UVMMC. And we'll just, Katie will talk about the AIM project, but just super excited to have her be the kind of latest member of the PQC coming in this week. And I also want to acknowledge that today Katie and I are presenting, but there's a whole lot of folks behind perinatal work at VCHIP, and including Brina, who's been our fearless leader, and many other faculty from the OB, MFM, NICU, pediatrician that are supporting this work. Maybe some background information is also that VCHIP has been doing this work in partnership with Family Child Health at the Vermont Department of Health for over 20 years. So it's been a very long time. Yeah, just want to give a shout out to all the folks that are involved. And about 2 years ago, we came together and decided to kind of follow the wave of PQC that are being built across the country, and kind of started to establish that structure, because previously you'll see in some of the slides, all this work was a little bit done unsiloed and not necessarily coordinated. So we came up with a mission statement, which is to optimize care and health outcome for perinatal people and infant. And really as probably many of you know, our bread and butter is to do a quality improvement project, but I like how Brina always states that we are a bit like the implementation arm of some of the work that VDH is doing. And this particular last year, I would say, our work has been really to try to extend that and work with community partner, including recently with working a little bit more closely with Building Bright Future. And on that note, just want to acknowledge your amazing report and presentation last week, and just the fact that you highlight the issue of pregnant people in Vermont. That was fantastic to work with you guys on this. How we do our work is that you'll see here in the goal is that 2 years ago, or not even quite 2 years, but we sat down with FCH. We work very closely with the 10 Community Hospital Birthing Center. We work with Pediatrician Clinic, just like Brina mentioned, OB, work closely with different team now at VDH. But it's try to set up here what's happening out there, what are the issue, and try to really get our team to focus on certain state perinatal priorities when they decide to do QI work, instead of kind of going all over the place. And we do this through QI project using IHI methodology, and also doing a lot of outreach and education. And today we don't have the data team, but we do have a small data team that is also trying to kind of organize their side of things to just streamline some of the data collection. Next slide. So as I said, as of October 1st this year, we are finally part of the purple wave, I would say. So we joined the 35 other PQC across the country that are receiving, that are supported by CDC to build a PQC in their own state. So the first pioneer of doing this type of model was California. And not too long ago, I can't remember if it's like 4 years ago, CDC has invested in supporting some of these states to do not only like kind of organizing their PQC, but also if you receive funding from them, you must also do a traditional QI project that use IHI. Next slide. And I would say that if you have seen Katie and I in Zoom meeting before, like really the last year has been, and also working with Brina, who's such a champion of this, has been the secret sauce of the PQC, has been to talk to people, has been to collaborate with folks. And so we just included here some of our key partner, including the community hospital, UVMMC, of course, where we have a lot of folks working on the project. And then we're involving a few people with lived experience. We're hoping this year with that funding that we can involve more people with lived experience. We work, 3 or 4 of us are actually on the MMRP committee. And we also work with NEPQUIN. Katie and OB providers actually sit on the steering committee of NEPQUIN. And we also receive, if you see at the bottom
Julie,
there, there's, yeah.
Sorry, can you just say what those acronyms stand for? You said MMRP and NIPQUIN.
Yeah, the MMRP is the Maternal Mortality Review Panel. The NEPQUIN is, oh my God, I'm gonna screw this one. What does it stand again? Northern New England Perinatal Quality Initiative Network. So that is actually a group that's based out of Dartmouth, and it's been around, Brina will know, but for many years. And it includes, it includes those 3 states, and they do, they mostly focus on education. They offer webinar, they do the AIM project, and they every year they do a fantastic conference at Mount Washington Hotel in the White Mountains, and then they have one actually coming up in February 15 if it's and then the NNPQC is actually, that's also part of the CDC funding, where they have they rally all the PQC together on listserv, different TA call where you can get technical assistance. Next slide. And then so today we'll just focus, but I like to see this as kind of our bucket of work for the PQC. As I said, those type of project or bucket of work have been siloed in the past. But really our goal with this PQC umbrella is really to kind of, even with our team, kind of show these are all the space we're involved in. Then we come together and can kind of assess where we have gaps and where we are not. I think today we'll just kind of very quickly review some of this work. Next slide. And then I'm kind of turning it over to Katie.
And I'm going to go a little bit quickly through this because you saw some of this data already, and also you'll have access to these slides if people want that. And but I just want to highlight the reason. One of the reasons why this data is important is it's really difficult to understand what happens in the postpartum period with a lot of our perinatal folks. And the 10 years of data that we've now been able to gather through in-depth case reviews of perinatal death, which is prenatal all the way through 1 year postpartum, has really allowed us to understand that postpartum period for that full year in a little more understanding. And, always acknowledging that this is a small subset of other issues in maternal health. Obviously, it's just people who have passed away. So this is just talking about how it was established. It's an active legislature asking for a multidisciplinary team to come together. We try to also regionally represent people, so not just different clinical and community representation, but also regional representation. Again, we reviewed perinatal deaths from all causes, pregnancy through 1 year postpartum, including situations of pregnancy loss. We also, so the goal of the panel is to review the deaths and to pull out factors associated with the deaths and create recommendations for the legislature. And also we create some recommendations for community partners to address what we are finding. Next slide, please. So this one just talks about our process. We meet quarterly. I'm the clinical abstractor for the panel, so it's all done very it's not identified, it's de-identified data. So I do the clinical abstraction piece and then I present to the panel de-identified, so they don't have any knowledge of who the people actually are. And we try to really protect their privacy as much as possible. And we do have a representative with lived experience on our panel starting this year, which is really exciting. And we hope to grow that piece, just like Julie was saying with the PQC. And then we also received a CDC grant for the maternal mortality review panel. It's 1 year of funding, but the plan is to apply for a 5-year cycle of funding, which will be not competitive. So it'll be hopefully a sure thing. Next slide, please. So this is just some of the data. You've seen some of this already, so this shouldn't be particularly new. The panel has definitely identified substance use and mental health as key priorities, which should not be that surprising after the presentation we had this morning already. And COVID-19, of course, we also know that just worsened all of the pieces around mental health and substance use. And I just want to highlight too, we think about substance use a lot and we often just think about opioids, and alcohol is definitely, although it's not the cause of death that we've identified, it's often involved in that postpartum period, as well as other substances we're seeing increasingly with xylazine and fentanyl and some of the other substances, which we don't have great data on. So next slide, please. So so this is just diving in a little more deeply. Like I said, we had 10 years of data to review this year, which was exciting to be able to really see some of the numbers, because each year is such a small number of deaths. We're lucky in the state to have a small number of perinatal deaths, but it makes it difficult to identify trends year to year. So the 10 years of data is really helpful. And surprise, surprise, this is the latest data from this year. 61% of cases were impacted by substance use, and then 46% were the direct result of accidental overdose or substance misuse. So that's, again, disheartening numbers, but not surprising. And then, like I said, polysubstance use is definitely increasingly involved. And generally speaking, we have 2 to 3 deaths a year. And then in 2022, through the cases that were identified in 2023 that we reviewed, there were 7 perinatal deaths, and they were all substance use related, which has been a change from previous years for sure. And then mental health is definitely impactful. 90% occur among people with a diagnosis, and many of them have multiple mental health diagnoses. And then suicide, again, 11% since 2012. So that's pretty significant there as well. And as we know, whatever data we're seeing here is the tip of the iceberg. These are people that pass away in the perinatal period. That means that there are many, many more people impacted who doesn't end in death, but are definitely impacted heavily. Next slide, please. So this is just talking a little bit about the timing of perinatal death. I put the national numbers and then Vermont's numbers to just sort of highlight a little bit of differences that Vermont sees. And the difference in Vermont, I think, because of our really excellent clinical care, and we see most of our deaths in the 3 to 12 months postpartum. So that's after they exit their obstetrical care. Pieces of that are the connection to adult primary care being really difficult. And so that clinical piece drops off. But then there's also other pieces where I think that the supports that perinatal people receive just generally drop off in that postpartum period. which is very different than the national picture. So next slide, please. This is a little bit about the race and ethnicity. I apologize for the visual graph on the left, and I updated the data for Vermont on the right, and I'm not very good at doing pretty pictures. So this is just bullet points for you all. Just to point out that the distribution of race among those who died is very similar to the distribution of race generally in Vermont, which is good in the sense that we don't have disproportionate impacts in our mortality data. Not to say that there aren't other pieces that are disproportionately impacted when we look at other issues of the perinatal period, but as far as death goes, it pretty much tracks our race and ethnicity data for the state. One note is that we actually have never had a perinatal person identified as Black die in the 10 years of reviews, which is very different. As if any of you are aware of the national data, that's a very different picture than most other states. All right, next slide. So this is just kind of thinking again, the second 6 months of postpartum is that priority period for substance use. The other thing that I think is just really important to remember is a second point, that of the deaths that we reviewed, there were people that were identified as stable in their medication treatment in pregnancy. There were a few people that was not identified as an issue at all. There was no known substance use disorder. And then there were a few people that were at high risk, everybody was worried about and trying to support and surround with services, but all of the people that we reviewed died of an overdose in the year after pregnancy. So I just want to really reinforce that what we see in pregnancy is not always the full picture. And so we really need to be aware of offering supports to all perinatal people because we don't know, and it's very difficult to identify sometimes what will happen in that year postpartum. Julie, I think you're next.
All right. I know we might run out of time, so I'm gonna go fast. I feel like this slide is now probably makes more sense with all that information from Dora and then from Katie, but for our group, just like I mentioned before, our focus area for this fiscal year that's gonna finish in July has been to just try to advance activity that support family well-being and mental health in the perinatal period, including the postpartum period, and really try to, kind of put some of our eggs into the issue of substance use disorder in pregnant people and also newborn who are exposed. Next slide. So how we try to do this work, and there's I don't know if folks are familiar, and I'm going to start on this side with the ICON initiative, but this has been a long-term project of VCHIP. It stands for Improving Care for Opioid Exposed Newborn. So in that space, we have expert clinicians that really follow babies that are exposed to substance use. They are part of our team. They offer technical assistance consultation to actually a lot of community hospital. I run a little listserv that has the 10 nurse manager that are on there, and I also host nurse manager meeting. And sometimes these guys will chime in on cases that the hospital see, or that they need, latest guidelines or protocol, how to deal with this. And of course, the ICON project also has many outreach and education activity. In terms of the first bucket here, where we say QI, to work on optimizing existing home visiting support into the system of care. This is how we became best friend with Margaret here on the call, to just like really trying not only to, how can I say that, really to try to translate to busy clinical providers who, are see a lot of patients, what does this whole piece of community resources that exists when those patients leave their office. So lots of education with our medical provider and practice, either through sometimes even like by inviting folks to come to the nurse manager meeting. So we really try to tackle nurses, provider, medical doctor, etc. And then on the other side, trying to do also increase training for the home visiting workforce. So meaning that, you know, just like I mentioned, you have a really amazing clinical expert that have the knowledge. Can we bring that knowledge? And we work on that with Maria, actually, who's on the call, to offer a training to her, the folks that she work with in terms of substance use disorder. And then we are also participating, many of us, actually, Katie, Maria here, and Dr. Shepard, Michelle Shepard, in the Vermont in-depth technical assistance. And I'm gonna let Katie talk about this. If you can go to the next slide.
Yeah, this is a initiative that we actually, several people on this call are involved in. Maria White, including Julie and I, and I'm not sure who else was called, but so it's just a support from our national partners at the National Center on Substance Abuse and Child Welfare. Trying to talk fast, it's not working well for me. Basically, it's an idea that we are doing an in-depth analysis of the various systems supporting perinatal people with substance use disorder and our family services division partners, and then creating some recommendations around improving the systems approach here for these folks, and also how we're also addressing the plan of safe care and some of the other pieces that involve the family services division partners as well. So it's really tying in well with the other initiatives around substance use disorder, which we'll go into. I don't know how much time we'll have, but there's just so much happening, which is exciting, but hard to fit into a PowerPoint. So yeah, and so you guys will have a chance to like look at this poster a little bit more carefully, but it's a really well supported and diverse selection of people participating from Vermont. So you see the key partner list there. It's really, really robust. It's been exciting. Oh, and here's the other one of the other projects, and I think Kayla Pinko's here on the call, who's really working hard on this. So this is we got a large grant at UVMMC to support this initiative. This is ongoing work. The AIMS work has been happening in Vermont already, but this is a chance to really enhance and grow this. And so these are national safety bundles that are used in multiple states and around various topics in perinatal health. And so the next one that we're going to be working on, that we're planning for right now, is care for pregnant and postpartum people with substance use disorder. Surprise, surprise. And some of the bundles that have already been rolled out are the hypertensive bundle and the hemorrhage bundle. So those are ones that the safety bundles have been rolled out in the clinical spaces. Primarily, this one also will be in the clinical space, but involve a lot of community partners as well, because we know that the supports and care are in a lot of different spaces for substance use disorder. Yeah, so it's rolling out in the fall of 2024. So like I said, we're in the planning phase. We're going to include the 10 Vermont community hospitals as well as UVMMC. And it's got a nice grant funding support, which is great. And we will, like I said, be laying this groundwork, and a lot of the other projects that we're working on are really going to support this as well.
Excellent. All right, so super quick, I think I already mentioned this, but we do we do try our best to involve family in our work. As of now, it's really been focused on SUD work. So we have 3 parents advisor with lived experience that participate in more and more, I would say, activity. At first, it was really just like share their experience in conference webinar, but now we also involve them in planning, especially around the VT-IDTA work, and also reviewing material that some of our, like if clinical faculty come up with material, sometimes we run those material by the perinatal advisor. We're gonna look for more folks to participate in our work, so I'm sure I'll be in connection with some of you to just try to involve more parents. Next slide. And this, I'm not gonna go too much into this because Dora mentioned it. So we are supporting support delivered campaign at VDH. There's one of my colleagues that works specifically on supporting the psychiatric perinatal consultation services. This is all about trying to make connection with already the existing connection that we have with the health, with the community hospital and practice across the state so that provider can use this service. Over the summer, we were wrapping up a grant called the STAMP grant. I'm sure many of you were involved with this. And we focused our last activity in 2 evaluation projects. One was assisting the system of care for screening, referral, and treatment of PMADs in Vermont. And all these documents, actually, you'll be able to find them on our website at VCHIP. But this one was really trying to look at kind of assessing what had STAMP done over the last 5 years. And it's really an interesting report looking at some of the challenge those providers face in offering screening. And then the second one, you can go to the next slide. You'll be able to also find the report for this one. This was a project that I have done that was part also of obtaining a degree, but it was to look at specifically what is the perspective of pregnant and postpartum refugee women that are resettled here in accessing screening, treatment, referral, and access to mental health services. So that information is on the VCHIP website. Next slide. And I just want to say, this is all the work that we're doing in terms of clinical community linkages. And that goes from, you know, a meeting with Gifford, who wants to know more about this home visiting, or how to connect women to WIC, or and how to, you know, educate their provider, from, you know, working with the UVMMC team in making a straight referral to in their EHR, so that, you know, the folks that are here working in Chittenden County will actually receive referral for them for home visiting or another services. So that's a whole bucket of work that's a little bit all over the place. And then Brina is also involved in the kind of the portfolio that's more around Dulce there. So maybe if we have time, she can chime in on this. Next slide. And then some of you have been, I think the FCHC have been invited, but every year here we do these perinatal statistic report, and we do conference with each hospital, and we kind of share, you know, you can see all these indicators there in these table figure to see where they are in terms of OB, pregnancy outcome and also newborn outcome. And we attach that to some QI goals that they decide to work on. So that's a huge report that comes in usually in May, but that is exclusive to the hospital community. And the next one, well, that's about AIM. Maybe we can just skip it, but it's just over the last 2 years, the OB team has been working on 2 AIM bundle. One was postpartum hemorrhage and the other one was on hypertension. They work on this with all the 10 community hospital in Vermont. And next slide. And then this is, so we have a whole group of new neonatologists and friends that are working in really, how can I say that? Increased skill of birthing hospital team outside UVMMC to care for sick newborn. And we just went for the first time yesterday. We just started this program, and we went out to a community hospital, and it was amazing. Just like that new creating these in-person training that are very focused on sick newborn. So, and this was identified as a need from those community hospital. And then next slide. And I just mentioned this before, but this is, we do nurse manager meeting. We invite them every year to VCHIP. They come, we do a tour of the UVMMC birthing unit, and we have lunch, and and for the rest of the year, we usually just do on Zoom every quarter. We host and we discuss it's topics that are either new for the either new project for VCHIP or topics that are interest to them. Next slide. And this, I talked about it, but it's just some of the education activity that we do, including April 9, we're hosting the annual Improving Care for Opioid Exposed Newborn. So mark your calendar. And next. And this was a very cool project that we did with all these, you see all the logos there. And it was under the leadership of the health department, but just to revamp some of the education material around infant safe sleep. And it was fantastic to work with this group of expert in prevention, and including a few clinicians that participated in this. And yeah, next slide. And then this is new as of like just a couple weeks ago. We have this amazing report that's really focused on the hospital, but we wanted to create something that was more, how can I say, more disseminate. So our amazing data manager, Avery, created a perinatal public health report. It's not yet on our website, but it just provides a snapshot of what's happening in the States. And she has also been able to create those in a district, so that gives a picture of each district, what's happening in terms of certain indicator around pregnancy and newborn. And I think I may have one more slide. Oh, and this is we're in the midst of doing this. So as part of the CDC funding, just like I mentioned earlier, we must do a formal QI project. And the community hospital team have been asking for doing something around birth certificate accuracy. So we are in the midst, our team of, and with VDH of kicking off that project so that we have better vital stats data spit out. So maybe actually BBF, you will be happy about this since I know you use that data too. Next slide.
Okay, guys, this is like pretty much the last slide. But this is just a kind of a little sneak peek. One of the things that we're going to be working on as a focus in FY25 is a really deep dive into individual regions and how to leverage perinatal work in different districts using the family child health coordinators, as well as supporting some of the coalitions and teams, and how do we create like sort of a network across Vermont that allows for all that lovely regional effort and focus on your own sort of needs in your region, but then also, really connecting statewide with those teams and making sure that they have that support and that sort of sustainability across Vermont too. So how are we supporting that and making it sustainable while retaining, regional flexibility? So that's kind of a very broad description of the next area of focus to knit together all of these projects we talked about today, which is just really hard to fit into half an hour. And next slide, please. The end. This is the VCHIP PQC email address. Feel free to reach out. We just threw a lot at you all. So Julie and I love getting emails, follow-up emails, so feel free to reach out.
Okay,
Thank
that was
you, Katie and
awesome.
Julie.
This is Brina. I just wanted to say 3 quick things to get great feedback. So awesome, and noted that Child Development Division CIS is not on our schema, and that's an oversight. So this part of the reason we came today is we have to use a lot of discipline to continue to remind ourselves that perinatal has many more partners than we've been able to assemble to date. So that's important. The second thing is, when you look, I really want to highlight, and you can see by the way Julie presents, we've done decades of work with the clinical side of this. This perinatal quality in Vermont began with just, ooh, let's just get the actual medical care right. And boy, has it paid off. We have incredible pregnancy care about the medical side. And when you meet with other PQCs around the country, they've got all the public health people and all the early childhood systems people and all the great efforts, but they don't have the medical side. So we're just trying to build off of the fact that we've got those folks at the table, sort of, right? I mean, OBs come in and out. And then I really just wanted to honor the MMRP has awakened in all of us that after we do very well with pregnancy care and birth, and then families head out into community and they need more eyes on, and they need to feel like they matter to us. And there are many opportunities for that, but I obviously have a bias. The pediatric office is a completely missed opportunity. I mean, those kids are going in with parents who are experiencing a lot. So that's why we're so obsessed with Dulce. So I'll stop there and just thank that great team. By the way, Katie and Julie are a great example of how important our work is relationally, because those 2 people hang out all the time. And so it's just snuggled it all in a way that's better for kids and families.
Thanks, Brina. Awesome. So we do have some time for reflections and discussion. If folks are able to turn your videos on, that always makes it a little bit easier, but understand if that's hard. So, and there's lots of love for Katie and Julie in the chat as well. So people are really appreciating the depth of projects and interventions that you shared. So others want to share their reflections, observations? Yeah.
So one piece of data, and I'm not sure how you would gather it, but I think it's sort of important to consider, is, and this is speaking again from anecdotal personal experience, but the number of people who leave their region because they can't get quality, culturally competent care. You know, and that's happened in my own family, where we've literally, my daughters have gone out of the county for obstetrics care because what's happened in this county has been so challenging for them. And I don't know if there's a way to track that, but I think that would be interested and important to know.
Yeah, I can't speak off the top of my head to tracking. That seems it's like it's got some complexity for sure. But certainly understanding, I mean, just our lack of diverse workforce in lots of different ways, both race and ethnicity, as well as you know, socioeconomic background and things like that. Like, it feels like there's a lot of unmet needs as far as representing the people that we care for. I definitely agree with that, and it's difficult to access representational care for sure.
Yeah, thank you, Kaya, for raising it as a continued gap and a question of like how can we, what is needed to be able to track that gap.
And it's even more than representational care, though that's important. It's care that's actively harmful because it's disregarding cultural norms for people. So, I mean, think about that. You're in labor and you're going over the mountain from Rutland to get to Gifford, which is what my family does. That's quite the drive to deliver. And it's been a very educational experience over the past 4 or 5 years.
Yeah, I think there's a huge amount of work to be done around stigma and bias and addressing that in Vermont. I mean, I feel like it's on the radar of people, but there's a lot of work. And this was just a conversation that Julie and I had with our parent advisory panel who are focused on substance use disorder, just that they were bringing up their experiences and, again, just a lot of work still need to be done.
I just want to add, Kaya, it's I love your perspective, and I'm gonna pencil it down as like, because it's funny how I've heard that anecdotally, but not in terms of race and ethnicity, but really in terms of bias around SUD, like that people will go somewhere else because they know that at this place, there's, bias because the person, so it could be a really nice, I actually don't know if any other states has done this, but kind of trying to track down why people would go there for a different reason, not just, yeah.
Yeah, and I'm happy to help you connect if you want some qualitative data because we know numbers are so small. But I know lots of people who would probably be willing to speak with you.
Yeah, thank you.
Thanks, Kaya and Julie. Other reflections on what you heard today and what stands out, what's new, but also what are the persistent gaps that we should be paying more attention to? Hi, Monty. I see Monty visiting with Dora.
I love it when kids join. My favorite.
Surprise classroom closure.
Right. Sorry about that. We're glad he's here now.
I can
Beth,
sympathize
this
with
is
Dora.
Anne. Oh, sorry, Maria, go ahead.
I was just gonna say I can sympathize with you, Dora. It was a late start, so that was fun.
Thanks, Maria. Go ahead, Anne.
So knowing that I might be risking getting into the weeds and that this needs a follow-up conversation, I just want to mention that the idea of continuing CIS, Strong Families Vermont responsive home visiting after 2 months postpartum to match with the Medicaid extension now goes through the full year, has been a topic at the state team, and that Katie and Julie have reached out, and we need to follow up with them. But that we would welcome perspectives not only from them, but from this whole group about that. And just very briefly, some of the questions we have are that the CIS payment model that allows a per member per month rate means that we're really trying not to sort of we're trying to consolidate Medicaid billing, and so really approaching the birthing parent and child and the family as a unit. And if we bill for both the birthing parent and the child separately, will that live into the model, or is it warranted given the new data that we have about the risks for the full year postpartum? So that's just, very briefly, some of the things that we're dealing with, and just to say that we would welcome discussion and input. So thank you for listening.
Thanks, Anne. Any other observations or gaps? I also think about the role of this committee, which is a great great group of folks showing up today. Thinking about both sharing information, what was done today about strategies and things that certainly I did not know to the depth of what was happening and what groups were convening. But what are the persistent gaps that may need continued kind of policy change and recommendations? Because this committee does have the capacity to make policy recommendations or bring ideas and concepts to the State Advisory Council to turn into policy recommendations, which we do annually. So I wonder if there are things that are kind of coming out of this conversation in terms of continued need.
Katie, can you talk a little bit more about the lack of universality?
Yeah, and I think Margaret and I were just talking about this yesterday. And it's you know, in all of the supportive services, I'm not just thinking of nurse home visiting, but using nurse home visiting as an example. If you go from a home health agency's perspective, for instance, offers a variety of programs. They offer the evidence-based, they offer responsive CIS, depending on the agency. They offer lactation, they offer medical, all these different services. However, they can't guarantee that anybody that's referred will get a service because it's based on insurance coverage and eligibility. So you can't, and I'm just going through, this is just one service, like I'm saying, and they all have, almost all of our services have some sort of caveat like this based on insurance, generally speaking, insurance coverage. And it's really problematic for multiple reasons, one of which is people don't receive care if they have the wrong insurance, which is very frustrating, obviously, but also for providers, medical providers, it's incredibly complex. It creates a system that is a huge barrier for referral because they can't just offer it to everybody and know everyone's going to get the same services because some things are covered prenatally and some aren't, and some things are covered postpartum. It's varying levels of supports that are covered, and it just creates this very difficult system. And Margaret, I see you want to speak.
Yeah, I just wanted to tack on to Kaya's point that recently in the fall, it was brought to our attention that the new IHIP immigrant health insurance doesn't cover community-based services. So CIS services are not a benefit to that population. So I just thought that would be worthwhile to include in this conversation as well. This has been addressed with DIVA policy as an oversight, and it's been recommended to track those who were referred and essentially unable to engage in preventative CIS range of service. So this could be Strong Families Vermont home visiting responsive, the Parents as Teachers program, and other CIS related services. One caveat is that because the Strong Families Vermont nurse home visiting program, aka MESH, is grant supported, they can engage in that program.
Thanks for that, Margaret. That's great. So we are coming to our time, and certainly some policy to track, and just invite this group that as you digest this, if there are kind of things that you want to bring back to this group in terms of policy needs, system gaps, or areas that we want to dive into. Our next meeting is on March 28th. So certainly lots of information. Any final reflections or announcements as we finish up? Okay, lots of thanks in the chat. Thank you. Yeah, go ahead, Dora.
Yeah, I just wanted to say, I think one of the striking things that Elisa, that hasn't been said directly, just about perinatal health is again that we have we sort of we know what we know what to do. We have we have 5,000 births a year. And so thinking about sort of the scale of the challenges and the supports that are needed, that it really is it's a problem with a scale that with the right inputs, we could make a huge difference.
Thank you, Dora. Okay, thanks all for showing up today. Really great to see you and hear what you're working on. Appreciate it. We will see you soon.